All right, Ari, thanks for joining me. We're going to do a prostate embolization today.
Wait, which procedure are we doing?
We're doing a prostate artery
embolization. Okay, gotcha.
And we're going to be showing you sort of our technique and system and what we use here to do this, okay?
Seems like you're almost done.
Yeah. Kathy, would you mind just turning the wheels for me one more time on there? Just turn them.
Just, Sonny, this is a radial PAE you're doing, huh?
Just turn them. Yeah, so we're going to be doing a radial PAE, and yep.
And so, how did you quickly? I guess how did you decide to go radial, to use your radial access for this patient?
Yeah, so in this patient, we decided because he's 5'6", no cardiac risk factors, no history of like a coronary stent, for example, in the past. So this was sort of an ideal patient from low risk of even having potential, say, for stroke. But definitely height was a consideration. For us, height, is obviously an issue. Patients who are 5'10" and under, those are the patients we typically will offer radial access to. The other thing that we will take into consideration now, of course, is that we have new longer catheters, should we want to use a longer catheter, that go up to over 170 centimeters in length.
Which catheter is that?
So we're using, for example, today the TrustSelect catheter, and that's what we'll be using to basically get access to the prostatic artery itself. It comes at 175 centimeters in length, 2.0 French.
Yeah. So that's a new that's kind of a new option for us. Previously, we were really only able to work with a 150 centimeter 2.0 French was the max previously.
Yeah, and so in your opinion too, what did you think in terms of the previous catheters? How often would you say that length of the catheter was an issue?
So that's a good question. I think over the years, so I think we first started doing radial PAE maybe 4 or 5 years ago. I think over the years, I've gotten more conservative with how tall I'll go. And the reason being is because, it's one thing just to get your microcatheter to the mid-prostatic artery, but a lot of times you need to advance it further to be able to coil embolize anastomoses, or maybe interrogate a distal pudendal branch or distal obturator branch. And so I found that my height limit has come down further. I think when I first described that, I said it's about 6 feet, and now I'm with you. I'm about 5'10". And so I was somewhat, we kept getting more and more limited with our current catheter lengths. So now with the 175 centimeter, it really expands whom we can perform radial PAE for.
Do you find that, and you've used this catheter already, I assume, right?
I have on a Thursday.
On a first person on a Thursday to ever use this catheter. Yeah. So, I mean, do you think it's by the way, just to show you here, we already have this.
You're already done. You're done with the.
I don't want to switch gears on you too quickly, but we got our wire down. You can see the TrustSelect going over our wire into the prostatic artery proper here. And we're going to take it, like you mentioned, this distal, we'd like to go really as distal as possible, mainly because if I want to avoid proximal non-target as well, seminal, vesicle, bladder, et cetera. But if we do need to coil a collateral. So we're putting that TrustSelect in the prostatic artery here, and we'll do a run. Our first run will be in an oblique position. Oftentimes we won't even do a AP if it's very clear in this view.
Right.
But here you'll see our oblique run, and this is a gentleman with a 100-gram prostate.
Yeah,
so
pretty large.
It's pretty nice. So pretty good perfusion to me.
Yep.
So you can see there actually, even in a 100-gram prostate, this artery is only about, let's say, 2.5 millimeters in size. So having the catheter, which is a small 2.0 French, is really beneficial because we're maintaining really good antegrade flow. But back to what you were saying, in terms of height and radial access and catheter length, this catheter tends to come in 175 and in a shorter 155 length. Here we chose, I don't know if you can see this well or not, but we chose a shorter length of the 155 because for his height, we don't need the 175. If we were doing your PAE, I think we'd probably have to go to the 175.
Yeah, maybe. I mean, it raises another issue though, because when you go to that longer catheter, you also need a longer base cath. Assuming that you
Yes.
want your catheter to be, you want your base cath to be sitting in the hypogastric artery, right? That's kind of the technique that we both use.
Yeah.
And that's how you get the best support for your advancing your microcatheter. So that's a problem that I've encountered, because if you go to a person over 6 feet, your 125 cm base cath may not reach into the hypogastric artery.
So what are you typically using in that situation?
Well, honestly, I haven't found a solution yet. What I'm really looking for when we're talking to our supply folks is I'm looking for something around a 150 centimeter, either Vert, Bernstein, or Cumpy type shape. I think that's going to be ideal, but I haven't identified it yet.
Yeah, I would agree. Even something even just slightly shorter, 140 might be good. So you have
140 would be good.
35 cm hanging out.
Yep.
Just so you know, we're already embolizing. So
Yep.
in this situation, we won't need to use any coils. So we're just embolizing with 100 and 250 micron particles, which you can see here. We're getting great staining of the prostate gland itself. So this is a really nice example of really just a really hypervascular gland.
Yeah.
Sorry, you go ahead.
I was going to say, let's go back to the anatomy in this patient for a second, because I saw your initial run. It looked like he had a prostatic artery, pretty big one, arising from, and so in this particular patient, you have a little bit of a variant, right? So you have the inferior glute that's coming off the posterior division with the superior glute.
You got it.
So your anterior division is really only made up, it looks like, and I don't see an obturator either, so I'm assuming
I don't.
Corona
Yeah,
mortis.
so it's made up of just a pudendal.
Yeah.
And off that pudendal really is a vesicoprostatic trunk, that very first branch.
Yeah. And it looked like you got in there pretty easily with your wire, and the TrustSelect tracked pretty well all the way through that tortuosity right there.
Yeah, and actually that tortuosity is pretty considerable. I mean, that's what we see, as you know, as the prostate gets larger, the tortuosity basically just becomes more redundant in the pattern of the prostatic artery. So getting down distally here, that was really critical. Do you, how often would you say that you're also using adjunctive techniques like coils, for example?
Yeah, so I found that I use it more and more, but it's still probably only about 40% of the time.
40% of the time?
Yeah.
Are you, and this brings up an interesting point. So when you're utilizing 2O catheters in that situation, what coils are you using? Having any difficulty with getting certain coils through? I mean, not really so much interested in brand names as much as I am just interested in, what your experiences or challenges are.
So we tend to use the same 018 pushable coils each time, and we don't have any issues with them in 2O catheters. They go through pretty easily.
Okay.
I know we are limited right now, and I don't use a lot of detachable coils in general.
Yeah.
But I know that there's a little bit of an issue with having a detachable coil long enough to go through the 175 cm microcatheter.
Yes. And also my other challenge I think I've seen is with the 2O catheters that are on the market right now, what are you using for your base wire in terms of diameter? Are you limited right now before TrustSelect, or how do you feel?
Yeah, so in general, I've been using 014 as my first wire. And that was, it's been that way for a while. My second choices are 016. So, and I don't usually go to an 018 wire. So, I think I haven't really been that limited up till now. But I can use the same wires all go through the TrustSelect. So it's kind of, I use my same wire array.
Yeah. So for myself, I think, I was using predominantly an 018 GT wire.
Yeah.
So now I can still use it, the same wire in this 2O catheter, which is nice. And then, of course, the other wire, the one I used during this case, for example, was an Asahi wire.
The Meister.
The Meister, and that works very well in terms of its radio opacity. And then the other wire I tend to use a lot is which is not so much a problem from Boston Scientific in terms of its size, because it's 014, is the Transcend wire. So the Transcend really hasn't changed. That could be used, obviously, as you know, in any of these, or just like the Fathom.
Yeah.
But I do sometimes prefer to use an 018, and I think with 018 coils and also with 018 wires, it is nice if you want to go back and forth, because not everybody wants to open up a two French catheter every time in the very beginning. Some people may reserve it for a smaller size gland
Right.
or smaller arteries. Yeah. How about you? What's your feeling on that?
On what size catheter?
Yeah.
I tend to go to the 2.0 immediately, and the reason being is because a lot of times you start with bigger arteries, and you can say, "Oh, that's pretty large," but then again, you might want to get into anastomosis and place a coil, or you might want to get into one of those distal branches, and I find for those a 2.0 is beneficial. So
okay, great.
Go straight.
Do you, one of the things I'm doing here is you can tell we got pretty good stasis already with these particles, and sometimes we'll finish up. I know you're a fan of this technique too, is sometimes we'll put a little gel foam slurry or paste in afterwards.
Yeah.
What I found is, we use a 1cc medallion to get it through there because obviously that paste can be very thick, and you'll see it here coming out in just a second. But with this catheter, I've not seen any difference in the ability to do that as well, even though we've also gone to a 2.0 French catheter as well. Have you noticed any challenge with that as well? Because just, here it comes. Here's that gel foam coming out. You can tell by the increased density, and this will be completely static here when we're done.
Yep. No, I think it's possible to get it clogged. I haven't seen it in TrustSelect. I have seen it in 2.0 French catheters in the past, but a lot of that has to do with how much you're putting in there and how quickly you'll flush with saline. So I think once you get used to using the gel foam slurry, it can be managed pretty easily without getting stuck each time.
Without getting stuck. Yeah, I think that's a really good point. What is for you these days with PA? Are you pretty much, I know obviously you have a busier PA practice than most, so this may be fairly atypical. When you speak to other folks, and what are you seeing is really the dominant types of cases people are doing? Large glands like this, or what are the typical kinds of cases people are getting? Are they getting surgical failures or contraindications? What are you seeing is the most common type of case?
Yeah, I think in general, I would say larger glands, maybe larger glands who are also anticoagulated. And then a lot of them are really difficult patients with a lot of comorbidities that urologists didn't want to put under general or spinal anesthesia. So those tend to be they're kind of the patients that we would say are the good patients for urologists to send over initially. So I think those are the patients that people are doing and when they start out their practice before they start getting self-referrals and such.
Okay. All right. Sometimes this happens to be a hypogastric. I think we won't have a problem getting in, but very, very rarely you'll get hypogastric arteries, which are really tortuous. And from a radial perspective, for example, it can be a little bit challenging, even when you get down the thoracic aorta to the pelvis, to say, hey, let's get into this hypogastric artery. There's certain times that, or certain catheter wire shapes, configurations you use for those patients who have really sort of sharp origins to their, or acutely angled origins to their hypogastrics.
Yeah, so looks like you got in there. That's great. I think you're limited a little bit, right? Because as far as the length catheter that you need from a radial approach, there's not a lot of catheters at a 125 length, at least not in our inventory here at the hospital. So I rely a lot on wires, and so I really like a shapeable glide wire. So I can put a custom shape in there to get me into a tough hypogastric origin.
Okay, so you like that for sure. I would agree with you. I think that's probably a nice way to get in. So one thing I'm going to do here is I'm going to repeat my run just because I'm a little high.
Yeah,
I'd like to just see a little bit lower. Yeah, exactly. I think it's a little bit lower, and then just repeat this run.
So just to recap on the last side, what size particles did you end up using over there?
Yeah, so I used 100s to start, then 250s really to finish, and then I used a little bit of gel foam paste at the very end.
And what's your cue to switch from the 100s to the 250s?
Yeah, it's a good question. I will say that, for me, once I see the absence of that early parenchymal staining, then I'll go to the 100s. I really want to get rid of that staining, get really good distal embolization with the smaller beads. I think one of the challenges with using because with too big of a range size is that we end up with, early embolization. And I think that early endpoint is really what I'm trying to avoid. Now, traded for some, obviously, maybe increased postoperative symptoms in terms of urinary frequency or dysuria. But overall, I think I'm very happy with really the clinical results. And I think that's something, I mean, you know this, everyone tracks their own clinical practice and really has to figure out what's working for them. But in the absence of seeing collaterals that I'm worried about, I will start with that 100 micron size. How about yourself?
Yeah, I mean, I tend to use either 200s or 400s, depending on the size of the gland. I think in this particular case, I probably would have used a little bit of a larger particle, just because it was a larger gland. But it's a lot of that, has to do with how much you're able to support those patients in the short term after the procedure. So
I think you're very right. In the perioperative time, that's really when, as you know, that's when you want to make sure that they're well taken care of. So here I'm in that answer.
Let's see where you're at right now.
Yeah, so I'll leave the wire right there just to have a supporting discussion. So at this point is, I'm in what I think is probably either an umbilical or vesicoprostatic or just another branch of the anterior division. But what I'm looking for here is, as I'm in this branch right here, I know the prostatic is right near the tip of this catheter. It could be just distal, just proximal. If we go back to the anatomy on the previous run here, you'll see this really well. It's a nice prostatic that you can see there just over the shadow of the external iliac artery. You can see that prostatic actually cross anteriorly. So what I'll do is actually, once I'm here, even if I'm not in it completely, I'll just do a run from here. I think that doing a run through the through the microcatheter and identifying, is it below this vessel? Is it above this vessel?
That looks like
where is it?
Pudendal there. Is that
Yeah, so it looks like I'm in the pudendal artery, right? Yeah. And
there's
you see where the prostatic is. It's right there, exactly. So just by doing that run through the microcatheter, I was able to see that. And as you know, sometimes the pudendal, the angle of origin off the prostatic in an RAO or LAO may not be ideal. So what I'm going to do is I'll switch a little bit here to an AP or sometimes a contralateral oblique, and I'll be able to see that origin even a little bit better. All right. And we'll do a run here, and there you'll see it. So now the prostatic goes off to the left side of the screen because, of course, you've taught me this trick. It's anterior. So there's the prostatic. So what we'll do is I'll just set this on tray. So I think, using the ability to inject and do imaging through the microcatheter, honestly, is really important. Something that I think is maybe not as often talked about or discussed is really how can you get good imaging through the microcatheter and then make your decision rather than like just fishing around and repeating your run or your base catheter in so many different angles.
Right.
I think that can be very frustrating, especially if you want to have a lot of throughput, and you want to be able to do a certain number of cases and not, struggle all day. Not to say that we won't struggle with this.
Yeah, I think that's a good point. I think, one of the main things I try to teach the younger guys, the fellows coming through, is that you should have a good reason for everything you do. I mean, don't just fish around with angles in different obliquities. Like, think about what is the purpose, what is the reasoning behind why I'm doing this obliquity.
Yeah, I think that's really key.
Do you think that's a common trunk right there with those two?
It's interesting you say that. It probably is.
There it is.
I think you're right. I think it is. I think it probably was a common trunk, which is why that wire was catching it. Yeah. And then the question is how distal, but you can watch this catheter just go.
Yeah.
It'll just go. Unbelievable. So made all the way down that far. Now I'm going to go back to a RAO projection because for me, that's the best to see whether or not we see rectal or pudendal collaterals. Wouldn't mind just click that. You can just click it off, Kathy. Thank you. You can just click it off.
Sonny, I'm going to have to sign off here, unfortunately, because I got a clinic appointment waiting. But
no problem.
That was this is a very fast PAE. Impressive.
Yeah, I think here we'll do this last run here on the right side. You'll see just to confirm when. I do appreciate Ari joining us, and enjoy the rest of your day in clinic.
Yeah, look at that. I just want to point out that stain that's still present on the opposite, on the contralateral side that you saw before subtraction. That's,
even before subtraction.
Yeah, that's the reassurance that that stain is still present, hasn't washed out. is a good sign that you've got really good stasis on that side of the prostate.
Yeah. And I'm really happy also to see how distal this catheter tip is, right at the capsule of the gland.
Great spot for Embo.
Yeah, really great for Embo. So I think from here, we'll do our Embo. We don't see any non-target vessels. So we'll Embo from here, and then we'll wrap up with a radial band.
Sounds good. Simple.
Thanks, Ari, very much.
Okay. All right.
All right, you take care.
All right, bye-bye.